So today I'm going to talk about the acute complications of the diabetes mellitus. We all know that the acute complication is one of the important reasons for which the diabetic patients are admitted in the hospital. And we must have a clear understanding that how we are going to manage the acute complications of the diabetes, because they are actually an important cause of morbidity and mortality of the diabetes mellitus. So let us have a look into the learning objectives of this module. We have to uh, learn how to identify, treat and prevent the hyperglycemic crisis, that is diabetic ketoacidosis, hypersmaller coma. We should learn to identify, treat and prevent hypoglycemia, another very common acute complications we face in our day-to-day clinical practice. And then I'll just touch upon a little bit about the landmark clinical trials through which we have learned a lot, and our understanding about the management of the diabetes has changed over the past few decades. So coming to the acute complications of diabetes, we are not going to discuss about the infection, which is also an important acute complications of the diabetes. Today, I'm going to discuss about the ketoacidosis, hypersmaller coma, hypoglycemia, and possibly it just will touch upon a little bit of the lactic acidosis part. So that is the intention of today's talk. We all know that there are lots of vascular complications of the diabetes also, say microvascular and macrovascular complications. There will be stroke, heart attacks. So these complications I'm not going to discuss in this module. I will specifically talk about the metabolic complications and not the vascular complications. So let us have a look into the first important complication, that is diabetic ketoacidosis. All of you are aware that the diabetic ketoacidosis usually occurs in type 1 diabetic subjects, but it may occur in type 2 diabetic subjects as well. So let us have a look into this case study, and you'll find that this is a 16-year-old boy who was brought to the hospital with complaint of vomiting, abdominal pain, and breathing difficulty. On examination, patient is drowsy, acidotic breathing, and the blood pressure was low. Pulse was 118, respiratory rate 28 per minute, and capillary glucose is 478. Patient is not known to have diabetes, and there is no family history of diabetes. So this is a very, very typical history which we find in this particular case. A young boy or a young girl came in the hospital with mainly of abdominal issues, but the patient has got some degree of drowsiness or neurological symptoms. And when the blood sugar was checked, it was found to be very high. So you have to suspect that something wrong with the patient, because only hyperglycemia cannot cause some kind of neurological symptoms. So this neurological symptoms actually give you an input as far as the important diagnosis is concerned, and therefore the question is, which one is the most important test that you will do to make the diagnosis of this patient? So the best test what we can do is checking the ketone bodies. So this is our routine advice to all our type 1 diabetic subjects and also type 2 diabetic subjects, that whenever the blood glucose level goes very high, say more than 300 milligram per dl, you should check the ketone bodies in the urine, and you should keep an urine ketose checks with you, and you should measure the urine ketone whenever the blood glucose level very high, to make an understanding whether the metabolic condition is actually decompensating or not. So this is the first important test we will do And the next question is, what are the two most important aspects of the treatment? We'll discuss it later, but as I can tell you that the most important two aspects of the treatment is to give fluid and give insulin. So these are the two mainstay of the therapy. You don't have to do any other thing, just you have to hydrate the patient properly and you have to give insulin to reverse the ketogenic process. So with this, I'll go through little bit understanding about the diabetic ketoacidosis. It is a state of metabolic decompensation which occurs as a consequence of severe deficiency of insulin. And there are three important diagnostic points and lies in the name of the diagnosis: diabetic ketoacidosis. So the person must have diabetes, hyperglycemia. In most of the situation of the decay, the blood glucose level is more than 300 milligram per dl. So we expect, before we make a diagnosis of diabetic ketoacidosis, to have a blood glucose level more than 300 milligram per dl. Usually it do not exceed more than 600 milligram per dl, and usually if the blood glucose level is less than 300 or 250 milligram, the possibility of decay is very, very remote. But I should not say that a patient with 250 milligram blood glucose cannot present as decay, but this is very, very rare. So what do we mean by hyperglycemia is basically the blood glucose level should hover between 300 to 600 milligram per dl in majority of the situation. The second point is diabetic ketoacidosis. So there must be ketosis. This is the second most important point by which we make the diagnosis. So presence of ketosis. You may check it in the urine or you may check it in the blood. So this is the second point. And third is the presence of acidosis, metabolic acidosis. So we have to check the arterial blood gas and you have to make a diagnosis of metabolic acidosis. So these 3 points must be fulfilled before we make a diagnosis of diabetic ketoacidosis. Now let us have a look into the definition or criteria for making the diagnosis. And as I have told you that the most of the situation, the blood glucose level is more than 300 or at least more than 250 milligram per dl. And then you must have an arterial pH which is substantially low. In mild case, it is less than 7.3. In moderate case, it is up to 7. And in severe, when it goes below 7. So on the basis of the arterial pH, the mild, moderate, severe degree is usually defined, but also it depends on the serum bicarbonate level. It basically goes hand in hand. If the bicarbonate level, if the pH level goes down, the bicarbonate level also goes down. And you must have the positive urine ketone, serum ketone. Osmolarity is variable and there must be a anion gap. And when the mental state also changes with respect to change in the arterial pH and the bicarbonate level. So when the patient is have a severe degree of diabetic ketoacidosis, they are actually in most of the situation have severe degree of drowsiness, stupor or coma. So the neurological symptom actually deteriorate over the progression of the disease or over depends on the severity of the disease. So coming to the few important useful formula what we commonly use in the diabetic ketoacidosis state to understand the serum osmolarity. And serum osmolarity can be measured doubling the sodium plus potassium value, and then adding with it is the glucose in milligram per dl divided by 18, and then adding with blood urea nitrogen divided by 2.8. So normal osmolarity is basically between 285 to 295, and this osmolarity is very tightly managed by the homeostatic system of our body. And in case of the diabetic ketoacidosis, in most of the situation, the osmolarity goes up, mostly because of the rise in the blood glucose level and also because of the rise in the blood urea nitrogen in some of the situations. Now, what we mean by anion gap, it is basically you have to measure the two important cation in our blood, that is sodium plus potassium, and then you have to then you have to subtract from this value the total amount of important cation, that is chloride and bicarbonate. So this basically, there is basically a gap between the two. We expect that the anion and cation should be same, but in the real scenario there is some difference. There are explanation because there are many cations which we actually don't measure. So anion we don't measure. So that is why there is a gap. So this gap conventionally is less than 10 or 11 milliequivalent per liter. So, and then you can measure the corrected serum sodium with respect to the glucose, because when there is a severe hyperglycemia, then usually there is a change in the serum sodium value, and then we can measure the corrected sodium value when we actually make a calculation on the basis of the glucose value in the blood. So coming to the precipitating factor for the development of diabetic ketoacidosis, the most important cause of the precipitating factor is the infection. And the second most important, yes?
Sorry to disturb, there is one question in chat box from Dr. Rijit Das.
Yeah.
Are you visual to see the chat box? Are you able to see the chat box?
Sure. Yeah.
Show conversation. Yeah.
Show conversation. Yeah. Let me see.
Shall I read the question?
Milliequivalent millimole. So it is in the millimole and milliequivalent are a little bit different. So they have given it both in milliequivalent and also in millimole. So you can use it any one. So both the value is there. So usually you can measure it in a milliequivalent, because the fact we actually measure the osmolarity we measure the most of the situation we measure it milliequivalent. So you can use the milliequivalent formula. So the diabetic ketoacidosis actually precipitated by the infection or the emission of the insulin. In case of type 1 diabetes, it is because of the omission of the insulin. Because we counsel our type 1 diabetic subjects and their parents that they should continue the insulin for the rest of the life, because insulin is basically life-saving for the type 1 diabetic subjects, as you can understand. So the child have to continue the insulin for the rest of the life, and most of the situation it is basically 4 times in a day. So we place the child in a basal bolus regime in most of the situation, and that is actually very, very painful to the parents. We understand that a young child have to take the insulin for the rest of the life almost 4 times in a day throughout life is a very, very challenging concept to conceive. So therefore, what happens in many situations, we have found that the parents try to check their luck in some other form of therapy, and when they stop the insulin and then they try the other form of therapy to reverse this type 1 diabetes, it is often devastating, because the fact they stop the insulin and because the fact they want to try their luck with another alternative form of therapy, which is non-existent, these child actually develop diabetic ketoacidosis, land up in the hospital with ketoacidotic state. It is our recurrent experience, despite the fact we counsel the parents and the child about the necessity of continuing insulin. Still, the people actually try to start some other form of therapy to avoid this injection 4 times in a day. The psychology is very easy to understand, but the consequence is very devastating. So that is why the omission of the insulin is another very important cause of precipitation of diabetic ketoacidosis. Now, other precipitating factor which mostly occurs in case of type 2 diabetes subjects when they develop diabetic ketoacidosis because of myocardial infarction, cerebrovascular accident, pancreatitis, alcohol, trauma, drugs. So these are basically occurs mostly related with type 2 diabetes who develop diabetic ketoacidosis, though the possibility of having diabetic ketoacidosis among type 2 diabetes mellitus is not very common. But type 1 diabetes often develop diabetic ketoacidosis, and the commonest cause for them is either infection or omission of the insulin. Now let us come into the pathophysiology of diabetic ketoacidosis, why it occurs. Now we have to understand that the glucose is a very, very important fuel, or we can say the glucose is the only fuel in some of the tissues, importantly the brain. Fortunately, the entry of the glucose into the brain don't depend on insulin. And that is why even in patients, those who have diabetes and have a very high blood glucose level, the entry of glucose into the brain is not impaired. So that is a very, very important understanding, and that is also a very, very important fact which goes in favor of the brain even though the patient has diabetes. Now the problem is that the peripheral tissues, especially the fat, muscles, they cannot consume glucose unless and until there is an insulin. So once there is no insulin, so what will happen that the tissue will suffer from calories. So it is basically a state of relative starvation. So once there is a state of relative starvation, so the body will try to mobilize the glucose from mobilize the energy from other sources. And the other source is the fat and protein. And that is why when there is a severe insulin deficiency, then what will happen that there will be proteolysis and there will be lipolysis, because the fact that the protein is broken down and lipid is broken down, and also body will try to break down more glucose, and therefore there will be glycogenolysis, because every tissue feels that there is no calories, no energy. So they will try to mobilize more glucose, and this mobilization of the more glucose is basically a counterproductive. Though they are mobilizing more glucose so that the demand can be fulfilled, but this glucose cannot enter inside the cell. So that actually contributes to the state of hyperglycemia, and there is a more hyperglycemia, severe hyperglycemia. So once there is a severe hyperglycemia, what will happen? This glucose along with the water will come into the urine, and so there will be loss of glucose and there will be loss of water, and there is a development of dehydration. Now, because of the fact that there is a lipolysis, so this lipolysis actually initiates the process of ketogenesis, and you can see that there is an increase when there is a lipid is broken down. It is broken down into glycerol and free fatty acid. Now the glycerol is basically goes into the gluconeogenetic pathway, and they produce more glucose and contributes into the hyperglycemic state. Now when you are broken down the amino acids and there is a production of the alanine and other amino acids, these amino acids will go into the gluconeogenetic pathway, and they will produce more glucose and contribute into hyperglycemia. So the amino acid goes into gluconeogenesis, producing hyperglycemia. The lipolysis will produce glycerol and fatty acid. Glycerol goes into the gluconeogenetic pathway and produce hyperglycemia. And the free fatty acid that actually initiate the ketogenic process or ketogenesis. And because the ketones are basically acid, so there is a formation of acidosis. So what will happen? Number one, there will be severe hyperglycemia because of the fact there is a glycogenolysis, gluconeogenesis, and because of the reduced glucose utilization. Why? Because there is no insulin. So because there is no insulin, no glucose utilization. So there will be severe hyperglycemia. Second, there will be loss of water and the glucose because there is a glycosuria. So because there is a glycosuria, so the water along with the glucose will come out into the urine, and there will be dehydration. Once the dehydration sets in, and when the intravascular volume goes down, there will be reduction in the GFR. This is a very, very important point to understand, that the reduction in the GFR is basically a very, very important incident in the pathophysiology of diabetic ketoacidosis. Once the GFR is low, it means that the glucose cannot come out into the urine, and that will contribute to further hyperglycemic state and hyperosmolar state. So the GFR is a or the renal function is a very, very important issue when we are considering the pathophysiology of the diabetic ketoacidosis. So whenever I look into a diabetic ketoacidotic subject, my first question is, how is the urine? If the urine is there or some amount of urine is there, it means that the kidney is working, because if there is a severe dehydration and if there is a severe reduction in the renal blood flow, there will be an acute tubular necrosis, and the patient can have renal failure, acute renal failure for a period, and that will take time to recover, and that makes the management of diabetic ketoacidosis quite complicated. But if there is some amount of renal function is there, if the patient is producing urine, then if we actually hydrate the patient, that will simply solve a lot of the issues, because once the hydration is there, GFR will improve, and because the kidney opens up, so the glucose will come out into the urine, so blood glucose level will come down. So kidney actually act as a safety valve as far as the diabetic ketoacidosis or hyperosmolar state is concerned. So if the kidney function is normal, then actually it prevents the patient from developing severe degree of hyperglycemia, because the glucose into the blood will come out into the urine. It will produce dehydration, but it actually protects against the hyperglycemic state. So when a patient develops diabetic ketoacidosis, you will find the symptoms of hyperglycemia, because it is a severe degree of hyperglycemia. So you'll find there will be polyuria, polydipsia, polyphagia. And because the fact there is an acidosis, so because there is a ketone body, so there is an acidosis. So once there is an acidosis, this acidotic state is associated with the GI symptom, nausea, vomiting, abdominal pain. Some of the patient may present with acute abdomen. And third, there will be neurological symptoms because of the hyperosmolarity, and you will find because the glucose cannot enter inside the cell, so there will be lethargy, malaise, headache, weakness. So these are the symptoms and signs of diabetic ketoacidosis, but they may take time to develop, maybe hours to days. So it does not mean all the patient will have neurological symptoms. The patient can have only hyperglycemic symptoms or gastrointestinal symptoms, a combination of the two. When the patient comes with the neurological symptoms, some say for example drowsiness, stupor or coma, it means we are dealing with a very severe case of diabetic ketoacidosis. There will be there will be symptoms in the respiratory system, too small respiration. Then there will be hyporeflexia, hypotonia, and the dehydration has its own signs and symptoms like orthostatic hypotension, poor skin turgor, and soft and sunken eyeball. And there may be hypothermia, smell of acetone in the breath. So these are the lots of symptoms will develop over a period of time. And for some, and the patient, as I've told you, may not have all the symptoms. The patient may come only few symptoms out of the whole list, and we have to check the glucose, look into the urine ketone, and if the both are positive, we have to check the arterial blood gas to see whether the patient is suffering from diabetic ketoacidosis or not. So if we look into the lab value of the patient with diabetic ketoacidosis, as I've told you, the glucose value usually go more than 300 milligram per TL or 250 milligram per TL. You will have the urine ketone strongly positive. Bicarbonate value is usually low. I expect to be at least less than 15 milliequivalent per liter. We should have pH 7.3 or low. If it is less than 7, it means we are dealing with a severe diabetic ketoacidosis. Sodium and potassium level is variable. Phosphate level is also variable. In most of the situation, the blood urea nitrogen creatinine value is slightly increased, but it may be because of dehydration. It may not always be because of the acute tubular necrosis. And once we start the fluid replacement, when the volume is restored, this rise in blood urea nitrogen and creatinine value can come down to normal level. So if we look into the management aspects of diabetic ketoacidosis, as I've told you, that the first part of the management is basically giving fluid. So if you do not know what to do with the diabetic ketoacidosis, if you do not know what is the dose of insulin, if you do not know how to manage the electrolyte and other issues, you don't have to do anything. You just give fluid, increase the intravascular volume, and if the renal function is normal, then it can make the things quite comfortable for you. So I don't believe in heroic management of diabetic ketoacidosis. I believe that the patient should be managed slowly and steadily. So we have some principles of the management of diabetic ketoacidosis. Volume expansion is the most important one. Then we have to start the insulin. And insulin is to correct the catabolism. That means the production of ketosis. So my first intention is not to correct the hyperglycemic state, which I think a majority of the people don't understand. So we don't have to correct the hyperglycemia. Hyperglycemia will correct on itself. So start the insulin infusion at a very low dose. Usually we start in a dose of 4 to 8 units per hour. That depends a little bit on the body weight. So you can start 4 to 8 units per hour depending on the body weight, and just wait and watch whether the patient is gradually improving or not, or hyperglycemia is gradually correcting or not. There is no point of correcting the hyperglycemia within few hours time. If it takes, say, 12 hours or 24 hours, it hardly matters. Be slow and steady. Glucose level, if comes down 30 to 50 milligram per DL, I am very happy as far as the infusion rate is concerned. Now then we have to look into the fluid, electrolytes and acid-base status. But once you have given the fluid, once you have started the insulin infusion at a low rate, it will correct the ketogenic process. And once it corrects the ketogenic process, the acidemia will get corrected gradually. We have to look into the precipitating cause. Most importantly is the infection. And in case of type 2 diabetes mellitus, as I've told you, we have to look whether the patient had suffered from myocardial infarction or not, a silver accident or not, if there is any drug exposure or not, or if there is any other important acute illness or not. So we have to follow the vital signs, say for example, blood pressure and pulse rate, temperature. We have to look into the urine flow. That is one of the very, very crucial thing. Always look into the urine. Urine is a very, very important sign. So if the urine flow is adequate, it means the kidney is working. And if the kidney is working, your 75% job will be taken over by the kidney itself. We do monitor the glucose, pH, and electrolytes. It is better to make a scale or flow sheet and check that how the blood glucose level is behaving, how the urine volume is increasing, or what is the urine volume, and check the potassium level. And if possible, sometimes we can check the pH also. We have to prevent the complications, and the very, very importantly, before we discharge the patient from the hospital, we have to educate the patient. Very importantly, especially if the patient has omitted the insulin infusion for which he developed the diabetic ketoacidosis. It requires repeated counseling to the patient and their parents that they are not supposed to stop the insulin injection, because if they stop the insulin injection, the patient will land up with the same situation again in near future. So in case of mild ketoacidosis, some people believe that we can give the oral hydration, not intravenously, and we can give the insulin injection subcutaneously, and we can check the blood glucose every 2 to 4 hours. But in most of the moderate or severe diabetic ketoacidosis, actually we have to treat the patient with intravenous fluid and intravenous insulin. So because of the fact that the patient cannot retain the oral fluid because of upper GI discomfort, there is a nausea and vomiting, and because the fact the patient has got an altered mentation, so we always prefer to give intravenous glucose and intravenous insulin. In almost all the diabetic ketoacidotic patients should be admitted in the hospital, and they should be they need a high dependency unit or the HDU or the intensive care unit where the patient to be admitted and monitored. So as I've discussed with you, that the most important issue that we are supposed to give to our patient is the intravenous fluid or hydration. So what fluid we will use? We will use normal saline. So give normal saline. And when you are giving normal saline, and as in one hand, and you will start the insulin infusion in the other hand, and when you are giving both, over a period of time, progressively the glucose level will come down. Say over a period of 10 hours or 12 hours, the glucose value may come down and reaches to the level of 200 to 250 milligram. At this point of time, when the glucose reaches at the level of 200 to 250 milligram, you should start infusing the glucose and the insulin simultaneously. I have seen that when the patient developed a normal level of glucose, say for the blood sugar level of 150 or 100, people stop the insulin infusion. And once you stop the insulin infusion, patient will again develop diabetic ketoacidosis. Don't do it. Continue the insulin infusion and continue the glucose drip. Why? Because the fact these patients are actually in a relative starvation state. So the patient have a lot of glucose outside, but the cells are actually starving. They have not received the glucose. Once you have given the insulin infusion, then the glucose will enter inside the cell and can be utilized. So therefore, it is our obligation to continue with the food and also to give the insulin, which will help the food to enter inside the cell. If you stop the insulin infusion, then again it will be a reversion of the process. And because of this reversion, what will happen that the patient will progressively develop the diabetic ketoacidosis again. So start normal saline, give normal saline over a period of time, keep on monitoring the glucose value. Once the glucose value reaches to the level of say 200 to 250 milligram per dl, then you will find that then you have to change or shift the shift the normal saline into the dextrose saline, so that the patient will receive the glucose as well. And you have to continue with the insulin infusion even if it requires at a very low dose. So coming to the next important issue as far as the management of diabetic ketosis is the insulin. If you do these two, then the patient will recover. Nothing more is required in most of the situation. So give insulin infusion. How much is the dose? As I've told you, a standard dose is 4 to 8 units per hour. You can actually calculate on the basis of the body weight. So 0.1 unit per kg per hour, that is the dose. So a 40 kg boy will require 4 units per hour, and an 80 kg man will require 8 units per hour. Very simple. So give 4 to 8 units of insulin per hour as an IV infusion. I usually don't treat my patient with IM route, so I have no experience of treating diabetic ketoacidosis with IM insulin. So always start an IV, and the insulin should be given separately in a separate hand, and the normal saline or the fluid should be given separately in another hand. So there will be 2 channels, and there will be 2 infusion bottles, which though will run separately. IV insulin usually we give in the syringe pump, and we have to check the blood glucose level every hour. As I've told you, I'm very happy if the glucose value falls 30 to 50 milligram per hour. That is more than sufficient. We don't require speedier fall of the blood glucose value. Rather, we have to give insulin continuously, low dose, to prevent the catabolism. You know, insulin in a low dose actually acts as an anti-catabolic agent. They prevent the lipolysis. Insulin in a high dose is basically anabolic. It promotes the glycogenesis. So insulin has got 2 basic actions. 1, it prevents catabolism. 2, it is an anabolic agent. In a low dose, it is anti-catabolic. In a high dose, it is anabolic. So what we require, we have to check the production of the ketone bodies. Why there is a ketone body production? Because there is a lipolysis. Why there is a lipolysis? Because the body is passing through a state of starvation or relative starvation. So because of the relative starvation, there is a lipolysis, and because there is a lipolysis, there is production of ketone bodies. So this lipolysis can be prevented if you give low dose insulin. So give low dose insulin. Don't try to correct hyperglycemia. This low dose insulin will stop the ketogenic process and will stop the production of acids, and that will reverse the ketoacidotic process. So as I've told you that when the blood glucose level reaches to 250 milligram per dl, we shift the patient to 5% dextrose or the with 0.45% normal saline, or you can give GNS solution as well. And we also have to check the electrolytes, blood urea nitrogen, creatinine, glucose every 2 to 4 hours until the patient is stable. How long we should continue the IV insulin? This is another very, very important question. You have to continue the IV insulin till the patient can eat orally. Because the fact that the patient have lot of GI symptoms, and unless and until the acidosis is corrected, the patient will not be able to take orally. So that is an indication that when the patient can take orally, indicates that the process of acidosis is actually almost over. So when the patient can eat orally, you can shift the patient from the IV insulin into the subcutaneous insulin regime. And in most of the situations, subcutaneous insulin regime means that we actually give a basal bolus regime. Basal bolus means we give 3 short-acting insulin and 1 long-acting insulin. So this is our conventional approach as far as when we shift the patient from IV to subcutaneous insulin. But actually you should continue the IV insulin. So 1 hour after we started the subcutaneous insulin. So give sub IV insulin 1 hour up to 1 hour after giving the injection of the long-acting insulin. So this is the way we shift the patient from the subcutaneous insulin, from the IV insulin into the subcutaneous insulin. So coming to the principle, all patients with decay need short-acting insulin. It takes longer to reverse acidosis than to treat hyperglycemia. A regular insulin should always be used, and we should give an intravenous insulin in an insulin pump. And if we give the intravenous insulin in insulin pump, and if we give it a low-dose insulin, that will reduce the risk of hypoglycemia, hypokalemia, and decrease the risk of cerebral edema. And there is no need to guess dose. You just continue with the same dose. Don't change with respect to the blood glucose level. And you just continue with the same dose, and it progressively improves the ketogenic process. But if over 2 or 3 hours, if you find that there is no change in the blood glucose level, it possibly indicate the insulin resistance. And if there is insulin resistance, then we have to up-titrate the dose, which may be double the initial dose. So from 0.1 units, we can increase it to 0.2 units per kg per hour. So as you can see, in the most of the situation, we expect a drop in the blood glucose level roughly around 10% per hour. I expect the drop, if it is between 30 to 50 milligram per DL, then I am very happy as far as the insulin infusion rate is concerned. So, so coming to the low dose IM insulin, as I have already told you that I don't treat DK with low dose IM insulin. I have no experience of doing that, but we have a very easy protocol to follow. Give the IM insulin every hour, check the glucose, and see how the patient respond to the intramuscular injection. So intramuscular injection actually has very important disadvantage is the discomfort of the patient to give IM every hourly. The patient is receiving IM injection. So on the other hand, intravenous insulin is quite comfortable as far as the patient compliance is concerned, and it is also easier to monitor the intravenous glucose, and we can actually up-titrate or down-titrate the dose of intravenous insulin as and when required. So I always feel more comfortable of giving IV insulin than giving intramuscular insulin. So this is the list of average electrolyte deficit in the adult. The most important point is the potassium. So if the patient are suffering from diabetic ketoacidosis, then in most of the situation, the patient will require a replacement dose of potassium. We may not replace the calcium, phosphate, magnesium, but in most of the situation, we have to replace the potassium because lots of potassium actually excreted into the urine, and there is a intracellular loss of potassium ion because of the acidosis. So acidotic process is associated with liberation or the excretion of the potassium from the intracellular space to the extracellular space, which is actually lost into the urine. So the intracellular potassium deficit to be corrected, and once you start giving the insulin infusion, then the potassium from the extracellular space will keep entering inside the cell, and there is a development of hypokalemia, which actually we can follow. And once there is hypokalemia, we need to replace the potassium to our patient. Now, if at the time of the presentation there may be a hyperkalemia and we don't have to give the potassium, because of the fact, as I've told you, because of the acidotic process, the potassium comes out from inside the cell to outside the cell. So initial presentation may be associated with hyperkalemia, and we don't give potassium initially. Once you have started the insulin infusion, potassium will enter inside the cell. So once the potassium keep entering inside the cell, the serum potassium level goes down, and when actually we have to start replacing the potassium into the intravenous fluid. The common dose is to give 20 to 40 millimole of potassium per liter of the fluid. So it means in a 500 ml bottle, we give 1 ampoule of potassium, and as we run the fluid, the potassium also enters inside the body. So you have to give the potassium not in an IV bolus, don't give it. So we have to give the potassium in diluted formation. So each and every bottle of the fluid, say 500 ml bottle, you can give 20 to 40 milliequivalent. So up to 20 to 40 milliequivalent you can give in one 500 ml bottle. I traditionally give 20 milliequivalent in each bottle, and then we check the potassium and see that how the potassium level behaves. In most of the situation, we have to replace lot of potassium because of the fact that the intracellular deficit of potassium may be quite high in this diabetic ketoacidosis state. Coming to the potassium, yes.
There is one request from Dr. Ajit to explain the
difference
between
IV and subcutaneous insulin. So I must tell you, I think I will discuss it again in the later part of this module, that how we should shift from the IV insulin to subcutaneous insulin. That is a very important area. Now I can tell you that how you can do it very quickly. You can see that say for example, the patient is getting IV insulin, and you have to calculate how much is the 24-hour requirement of this particular person. Now, you are treating this DK patient for the last 1 day or 2 days, and you know the patient is having the blood glucose level around 200 milligram or 150 milligram per dl, and you are infusing the insulin at a rate of say 3 units per hour or 2 units per hour. Say for example, you are giving 2 units per hour. So if you are giving 2 units per hour, just look into the insulin infusion rate in the last 4 to 6 hours time. So in the last 6 hours time, the average insulin infusion rate, say for example 2 units per hour. So calculate only the last 6 hours time. 2 units per hour is average. If it is 2 units per hour, it means in whole 24 hours, the patient will require 48 units of insulin. So 24 into 2, 48 insulin, 48 units. So 80% of this total calculated dose should be given into the subcutaneous dose. So if it is 48, 80% of the 48 is roughly around 40 units. So if the patient is receiving 24-hour insulin replacement of roughly around 48, you have to take 80% of the 48, so 40 units. Now this 40 units of insulin to be divided into the basal bolus regime. Now how much will be the basal and how much will be the bolus? Now basal will be 50% and bolus will be 50%. So 20 units will be the basal and 20 units will be the bolus. So we will give a long-acting insulin of 20 units and we'll give 3 short-acting insulin, 777, or you can give 776, whatever you like if you want to make it 20. So this is the way we divide. This is the standard way by which we shift the patient from the IV insulin to the subcutaneous insulin. This is a matter of calculation. You have to calculate and you have to give, and then you have to check that whether it is working or not, and you have to titrate the dose accordingly. Now coming to the bicarbonate therapy, now among the patient, those who are suffering from diabetic ketoacidosis, I am very, very reluctant to give bicarbonate therapy. So I believe that if you give insulin infusion, it will correct the acidosis. Once the acidosis is corrected, progressively the patient will improve. There is no point of giving bicarbonate therapy. But if the patient have got a pH less than 6.9, which may be associated with significant impairment of the cardiac function, then possibly we have to treat the patient with bicarbonate infusion. So, but the bicarbonate infusion has got a lot of problem. Number one is that it increases the sodium value, so there may be hypernatremic state. That's a very important issue. And you are actually loading the patient with some volume. In some of the patients where the cardiac dysfunction is an important issue, because of the fact the pH is very low, they are basically cardiac compromised patient. So the volume overload may be an important issue as far as this kind of patient is concerned. So basically, I must tell you that I am not interested of giving bicarbonate. So don't treat a diabetic ketoacidosis patient with bicarbonate therapy unless and until it is a dire necessity. So treat the patient with insulin. Be slow and steady. I must repeat, be slow and steady. There is nothing to hurry. There is nothing to correct the hyperglycemic state within 2 hours time or 3 hours time. Don't do it. Give slow, low dose insulin continuously, slowly. The ketogenic process will take time to get corrected. Hyperglycemia can be corrected faster than correction of the ketogenic process. If the hyperglycemia is corrected, it does not mean that we have to stop the insulin infusion, because the ketogenic process requires more time to get corrected. So continue the insulin infusion along with the glucose trip. That will correct the ketogenic process. And the indication of correction of ketogenic process depends or are reflected on three things. Number one is the GI discomfort will disappear symptomatically. And second, you will find that ABG will improve. So these are the two things we look into it. Urine ketone may not change much over a period of time. So don't look at the urine ketone values. It will take time to disappear from the urine. But if the patient symptomatically improves, GI symptom disappears, and if the ABG value improves, it indicates the ketogenic process has stopped completely, and you can shift the patient from the IV insulin to the subcutaneous insulin. So there are a lot of complications of diabetic ketoacidosis. The most important complication is infection, arterial thrombosis, and the shock. So these are the three important complications. And mortality of diabetic ketoacidosis is quite high. It is 10%. It is almost same to that of hyperosmolar coma, but it has got slightly higher mortality, say 10 to 20%. One of the important complications of diabetic ketoacidosis is the cerebral edema. So we have to understand that if the patient has improved and then progressively develops some change in the neurological symptoms, then you have to suspect the cerebral edema. The diagnosis can be done if we do an CT, and if the patient develops cerebral edema, we have to treat the patient with mannitol or glucocorticoid. Now, there is an explanation that how cerebral edema occurs, though we don't know the exact pathophysiology of the cerebral edema, but this is the mechanism which is mostly put forward as an explanation for the development of cerebral edema. Now, if you can see that the patient who is gradually developing hyperglycemic state, as because there are a lot of glucose outside the brain cell. If you consider this as a brain cell, then there is a lot of glucose outside the brain cell, and as because there is a lot of glucose, so there will be tendency that the fluid from inside the cell will go out. So the brain will develop some kind of protective mechanism by which it can retain the fluid inside the brain cell. So it prevents the brain cell from getting dehydrated. So this is a method by which the brain try to preserve the intracellular milieu, and they develops the idiogenic osmoles. So they develop idiogenic osmol. So intracellular osmolarity goes up, and it matches with that of the extracellular osmolarity, which is mostly because of the glucose. So glucose increases the osmolarity outside, and idiogenic osmoles inside the brain cell increases the osmolarity inside. So there will be no shift of the fluid, and the brain cell remain intact. So this is a stable situation. Now, once you have started treating the patient, with intravenous fluid and insulin, then what will happen? There will be a fall in extracellular osmolarity because there is reduction in the glucose value. This is another reason why we do not want to reduce the glucose value very quickly. So once the glucose value goes down, there's a fall in extracellular fluid osmolarity. And as there is a fall in the osmolarity because of the low in the glucose value, what will happen? That the fluid from the idiogenic osmoles are there inside the cell, so they will draw fluid from outside to inside, and there will be swelling of the brain cell, and that leads to cerebral edema. So ketonemia or ketonuria, how long it takes to disappear? As I've told you, it may take 24 to 36 hours time to disappear. So if you treat the patient properly, it will take, say, roughly around 1 to 2 days. So therefore, keep on continuing the patient for a long period of time. But the acidosis improves much earlier, so you can shift the patient from the IV insulin to the subcutaneous insulin in 24 to 36 hours time. So bicarbonate, actually, you have to give a lot of bicarbonate. It is 7.5% bicarbonate is there in a 10 ml ampoule. And if you want to give bicarbonate therapy, then you have to give roughly around, we give in a syringe pump, and though I don't like it, sometimes it is given. So it is given in a syringe pump, and you can load it with, say, 100 ml bicarbonate. Our idea is to correct the pH up to 7.1. So that you should measure. So don't give bicarbonate if the pH is 7.1 or more. No, never. So just correct the pH from less than 7 up to 7.1. So this is about the cerebral edema. Now, looking into the general care, ECG before administration of the potassium, but usually we check the serum potassium level. And we have to look into the urine output, the vital signs, neurological signs, frequent assessment of clinical status, protection of the airway in some unconscious patient, nasogastric suction in some of the patient, and chest radiograph is important, very important, because often infection is a precipitating factor for the development of diabetic ketoacidosis, and the pneumonia or the chest respiratory tract infection is a very common offender as far as the precipitating factor for ketoacidosis is concerned, especially in an elderly subjects who is suffering from type 2 diabetes mellitus. They can have pneumonia, and a pneumonia actually can precipitate the diabetic ketoacidosis. Another important fact for the diabetic ketoacidosis is to search for a precipitating factor. As I have told you, the infection is a very important precipitating factor. Most of the situation, hypertension respond adequately with the fluid replacement, and you don't have to give anything like the dopamine or dobutamine, something like that. Don't require any pressure agent to improve the hypertension. Hypertension respond very well with adequate fluid replacement. Central venous monitoring is required only in an elderly subjects where cardiac disease is present. It is not required in case of children. And frequent ECG monitoring is required for hyper or hypokalemia. And cerebral edema, as I've told you, to be treated with the mannitol or dexamethasone. Brain imaging to exclude other pathologies, especially the stroke in case of elderly subjects. Adult respiratory distress syndrome can occur very rarely, and thromboembolic complications. Mechanical ventilation is required very, very rare. I have never used mechanical ventilation to correct this severe acidosis. In diabetic ketoacidosis, in most of the situation, in children, no question of mechanical ventilation. In almost all situations, you just have to give fluid and insulin, and ketoacidosis will progressively improve. The mechanical ventilation to eliminate the severe acidosis is a need only among patients, those who are elderly and develop diabetic ketoacidosis from type 2 diabetes mellitus, not from type 1 diabetes mellitus. So coming to the pitfalls in the diagnosis of the diabetic ketoacidosis and pitfalls in the management as well. The smell of acetone, which is an important marker of diabetic ketoacidosis, may not be apparent in some of the situation, because I may be anosmic and for the acetone, so I may not able to smell the acidotic breath. So you have to remember, fever is often absent even though there is an infection, that we have to remember. Blood leukocyte normally get elevated. It does not mean that the patient has infection. And serum sodium concentration may be falsely lowered because of the excess amount of lipid and glucose level, because there is a lot of, as I've told you, there is a lipogenesis. So because there is a lipogenesis, there is a production of free fatty acid and glycerol. As I've told you, glycerol goes into the gluconeogenetic pathway, and the free fatty acid, they actually either they produce the ketogenic, they go into the ketogenic pathway, or they can be converted into the liver into VLDL, very low density lipoprotein. So VLDL production by the liver goes up. So there are a lot of lipids in the blood. So because of the presence of lipid and the glucose, there may be falsely low value of the sodium. So we call it spurious hyponatremia. So we have to keep it in mind that there may be a spurious hyponatremia when we are dealing a case of diabetic ketoacidosis. Now, serum potassium concentration, as I've told you, initially it may be high, but because of the fact that the intracellular potassium has come out into the extracellular space, but patient actually suffers from potassium deficit because there is an intracellular deficit in the potassium. As you know, potassium is basically an intracellular ion, and in the extracellular fluid concentration of potassium is roughly around 4 to 5 milliequivalent per liter, whereas the intracellular potassium is roughly around 140 milliequivalent per liter. So therefore, there is a severe degree of intracellular potassium deficit, and when you start the insulin and the fluid infusion, then the potassium will re-enter inside the cell, and that will lead to decrease in the potassium into the extracellular fluid. Creatine concentration again can be falsely elevated, as I've already told you, because of the volume depletion. Ketosticks, when you are checking the patient with ketosticks, the ketostic reaction may become temporarily stronger during the treatment or decay because of conversion of beta-hydroxybutyrate to acetoacetate. So don't depend on the result of the ketosis. You have to look whether the glucose value going down or not, whether the patient symptomatically improves or not, and very, very importantly, whether the renal function is adequate or not, patient is passing good amount of urine or not. So these are the few facts which we have to consider while we treat our type 1 decay subjects. there may be non-specified rise in the transaminase and creatine kinase for which we don't have to do anything. So now we will talk a little bit on the hyperosmolar hyperglycemic state, or we sometimes called HONC, hyperosmolar non-ketotic coma or non-ketotic state. So I'll start with a case study. This is a 82-year-old man and 82-year-old lady with diabetes mellitus for 6 years duration, and she was on oral hypoglycemic drugs and admitted to the hospital with confusion and with focal pits. Remember that the hyperosmolar non-ketotic coma often comes or mostly comes with neurological symptom. On the other hand, in DK patient, they usually don't have neurological symptoms. If they have neurological symptom, it is a severe case. So this is the difference between the two. And usually they don't have ketonuria. There is no ketonemia in the blood. pH level usually above 7.3. There may be slight reduction in the pH, but it usually don't go below 7.3. So there is not much acidosis and there is no ketonuria. So there are two important issues or two important difference between the two. One, that there is no ketonuria and there is no acidosis. So even if there is some degree of acidosis, it is not below 7.3. Third point is that they have a very high blood glucose level, more than 600 milligram. More than 600 milligram blood glucose usually we don't see in diabetic ketoacidotic patient. I should not say we will never see, but I should say mostly we don't see in diabetic ketoacidotic subjects. But in hyperosmolar coma, we find that it is almost always more than 600 milligram per day. And you will find that there is some rise in the urea and creatinine value as well because of the dehydration. Mostly it is found among elderly subjects and develops among patients those who have type 2 diabetes. But let me tell you, a type 1 diabetic patient can also develop hyperosmolar coma. So this is the the diagnosis. If I ask, the diagnosis is basically hyperosmolar coma in this particular issue. So some technical error. Am I audible? Visible?
Yes, sir.
Okay. So, so if we look into the characteristics of the hyperosmolar state, you'll find this mostly found in the elderly patients who were undiagnosed type 2 diabetes mellitus, or those who were actually previously diagnosed with type 2 diabetes mellitus, mostly actually on oral hypoglycemic agents. And the very important issue as far as the development of hyperosmolar state is the not taking adequate fluids. So this is a very important issue. So why they are not taking adequate fluid? Maybe because the fact they don't feel thirsty. So thirst mechanism may be impaired in an elderly subjects. Second point is that even though they are thirsty, they are reluctant to go and take a glass of water. There may be some limitation in their movement for which they are not going and having water. And this is actually becomes more severe if they are living alone with little support system. And in abroad, you will find that those who are living in the nursing home, they develop this kind of problem more because they are living unattended in most of the situation. So basically, what I like to emphasize on you that the taking adequate fluid is a very, very important issue. And because the fact they are not taking adequate fluids, whatever may be the reason, it may be because of this social circumstance. It may be because of the limitation on their part as far as the movement, as far as the vision, as far as the kinetic energy is concerned, or it may be because of the old age. They are not thirsty, and that is why they are not taking the adequate fluid. So these patients actually have a little amount of insulin in their body, and as because they have some degree of insulin in the body, therefore the ketogenic process is not there. So that is why they do not develop diabetic ketoacidosis. The precipitating factor may be infection, severe stress, hypokalemia, renal failure, and fluid intake is one of the very, very important cause of the development of the hypersmaller coma. So insulin deficiency, but it is not an absolute insulin deficiency. Some degree of insulin is present. As because the some degree of insulin is present, as I've told you, insulin in low low insulin low dose actually prevent the development of ketogenic process. High dose is basically anabolic. So because the fact they have low insulin, low amount of insulin in the body, that actually prevent the development of ketogenic process. But because the fact there is an insulin deficiency, there is an hyperglycemia, the glycosuria, and once there is a glycosuria, there is a lot of water comes out, and there will be hypovolemia, which leads to hypovolemic shock, prenatal acidemia, the urea creatinine goes up, and that can lead to death. So this is basically occurs mostly because of the not taking adequate fluid, which is precipitated by some infection, maybe sometime some other acute insult, say for example cerebrovascular accident, which we commonly see among our elderly subjects. Lipolysis itself is again basically inhibited by the hyperosmolar state, which we find in this kind of situation, because the blood glucose value is very high. It goes more than 600 milligram per TL, so it means it produces a hyperosmolar state, and as this is an hyperosmolar state, the lipolysis is actually inhibited. Lipolysis is also inhibited because the fact that the insulin is not completely absent. Some amount of insulin is there in the body because it is developed among patients those who are type 2 diabetes. So some amount of insulin is there, and that prevents the lipolysis, and that prevents the development of ketogenic process. So insulin deficiency is not profound. There is no increase in the lipolysis, but there is severe hyperglycemia, but the ketosis is not there. There's a profound dehydration, and the most important presentation is a neurologic manifestation. Lack of ketosis and acidosis is associated with no or minimum GI symptom, because GI symptom develops because of acidosis. So as there is no acidosis, so there is no GI symptom or very little GI symptom, if at all. Due to lack of acute symptoms, the patient do not seek medical care quickly, and they remain in house and don't take any water, and that actually leads to further dehydration because the blood glucose level goes up. So there will be osmotic diuresis, there's further dehydration, decrease in the renal blood flow, extreme hyperglycemia, and that is associated with neurological changes, and they present with neurological features in most of the situations. So signs and symptoms, few symptoms are similar to the decay, but we don't find the GI symptoms much. The frank coma is a common presentation, which is not common with decay, but we can also find some neurological signs which mimic cerebrovascular accident, hemisensory deficit, hemiparesis, aphasia, seizure. And remember, all these neurological deficits are reversible once you treat the patient. So these neurological deficits are not permanent. If the patient do not have a cerebrovascular accident, but this patient may have neurological signs which mimic cerebrovascular accident. So if there is no cerebrovascular accident, these neurological signs of hyperosmolar coma is basically reversible. So we have to do some laboratory test, complete blood count, chest X-ray. We have to try to identify the precipitating factors, and blood glucose level is usually more than 600 milligram per dl. The ketone values are usually negative. There may be 1+, but osmolarity is always elevated because the blood glucose level is more than 600. So if we calculate the osmolarity, it is always more than 300. Now you can see that the most of the patient, those who have the osmolarity of more than 300 up to 315, they actually remains in an alert state. But over progressive increase in the osmolarity, the grade of consciousness goes down. So therefore, osmolarity is a very, very important issue as far as the neurological symptoms is concerned. And as I've told you, neurological symptom is the commonest presentation as far as the hyperosmolar coma is concerned. So changes in the mental status do not occur unless the osmolarity raises above 320, and it progressively goes down with further progression of further rise in the osmolarity, level of osmolarity. So primary goal is to rehydrate the patient. Here again, the insulin to be given in a very low dose. Insulin is secondary. The primary importance is to correct the dehydration. Once you correct the dehydration, then the glucose will come into the urine, the kidney will function, glucose will come into the urine, and the blood glucose level goes down. So we start the insulin as well, again in a low dose, and we have to prevent the complications because of the treatment. Which complication? Because if we give the very high dose of insulin, there's a possibility of hypoglycemia. Don't give it. Give a very low dose of insulin continuously, long period of time. We have to check the precipitating factor. Often hyperosmolar coma is associated with some precipitating underlying medical condition. As I've told you, sometimes it may be an infection, sometimes it may be a cardiovascular event. So these are the things we have to look, and we have to correct the underlying medical condition. And many patients of type 2 diabetes mellitus who develop hyperosmolar coma have multiple other complications as well, because this is the disease of the elderly people, and the elderly people most often have some other issues as far as their comorbidities are concerned, and that should be addressed when we are treating a patient with hyperosmolar coma. Very, very importantly, when we release the patient, we have to educate the patient as far as the taking adequate amount of water is concerned. As I've told you, in some of the elderly subjects actually have a defective thirst sensation, and that is why they don't take water. And as because they don't take water, they actually are more prone to develop hyperosmolar coma. Now, the fluid replacement depends on the patient's state of hydration and cardiovascular status. Start the patient of half normal saline. If the serum sodium levels are low, then the normal saline can be instituted. Hydrate the elderly patient with caution because they may have some cardiovascular issues in the backdrop. and the patient need to be assessed frequently for the signs of heart failure, and patient with history of cardiac disease should be monitored with central venous pressure. So in insulin, same as the decay, but we can give much lower dose, and if the patient is sensitive to the insulin, monitor the glucose or electron 1 to 2 hours until stable, and decrease the insulin when blood glucose level reaches about 250 to 300. As we do that, we have to start the glucose infusion along with the insulin when the glucose value goes between 200 to 250 or 250 to 300. Identifying the high risk patient is very important, and we have to educate the patient and the family as far as this important disease is concerned, because this particular issue is associated a lot of morbidity and mortality, and the mortality is higher compared to the decay subjects. So let us have a look into the comparison between the decay and HHS. Usually the decay occurs in the younger subjects, especially in type 1 diabetes. HHS occurs in elderly subjects, mostly with type 2 diabetes, but both can occur in either age group. Symptoms: the development of decay occurs within 2 to 3 days, whether HHS develops over 5 days to 7 days. As I've told you, decay, usually blood glucose level varies between 250 or 300 to 600 milligram. In HHS, it is always more than 600 milligram. Sodium level, potassium level, they are more or less variable. Bicarbonate level, we don't expect much change if the patient has got a hyperosmolar coma. Ketone body in decay, there must be ketone body present in the urine as well as in the blood, but in HHS we do not expect ketone bodies. If it is present, it will be in mild degree. pH in decay, it should be less than 7.3. In HHS, it should always be more than 7.3. There may be some reduction of pH may be there, but it should not go below 7.3. Osmolarity in HHS, the osmolarity is always very high, at least more than 320, if not more than 350. Cerebral edema can be present in decay. Usually cerebral edema is not an issue with HHS while we treat our patient, because I have told you mortality in decay is low compared to HHS. HHS has got a much higher mortality because this is the patient who are actually type 2 diabetic. This is basically an elderly subjects. They have multiple other complications, and often they develop HHS because of an cardiovascular events or a cerebral event. So the mortality rate is much higher among the patient who develop HHS compared to decay. Now, subsequently, after the patient came out of the problem, in decay, patient always require insulin, but in HHS, the patient may not require insulin because these are the patients who actually suffers from type 2 diabetes mellitus. So I'll take a break of 5 minutes, then we'll start the second portion. So if you just a 5 minutes break.
Dr. Shajal and Dr. Rudra, kindly complete your pretest activity. I'm pasting the pretest password in chat box.
all the patients who suffers from type 2 diabetes mellitus are prone to develop hypoglycemia, because the fact we treat our patient with anti-hyperglycemic medication, and therefore sometimes they develop hypoglycemia. Now, hypoglycemia uh, is not unavoidable in most of the situation, but we should try our level best to manage our type 2 diabetic subjects with complete avoidance of hypoglycemia. Again, I understand it is not possible in many situations. So let us have a look into this case study. Mr. G, a 44-year-old who had type 2 diabetes for the last 6 years and is on glipizide 5 milligram twice daily and metformin 1000 milligram per day. His fasting blood glucose is 96 and PP is 126 milligram per day. Now his H1C is 6.4. He complains of headache, inability to concentrate, and nervousness at around 5 p.m. every day. His symptoms disappear after taking coffee and biscuit. Now, if you ask this question that what is the cause of his symptom, you can see that the H1C is 6.4. It means his blood glucose level is quite controlled. And this symptoms is possibly because of the development of hypoglycemia. So how we can prove the diagnosis is just to make a blood glucose test at the time when the patient develop the symptoms of inability to concentrate or nervousness. This is the best way to diagnose this condition. Now, what precautions will you take in this patient? The precaution is that it is better that we should avoid the drug which is responsible for producing hypoglycemia. In this particular case, it is glipizide. In some other case, it may be some other agent. So we will try to avoid the drug which causing hypoglycemia when we can shift the patient to some safer agent. Now, coming to the diagnosis of hypoglycemia, it is conventionally and traditionally taught that it should fulfill this Whipple's triad. Whipple's triad means there will be symptoms of hypoglycemia, and the person must have checked his blood glucose. It means he has documented that blood glucose level was low. And third, that the symptoms has disappeared after administration of carbohydrates. So these three must be fulfilled to get a diagnosis of hypoglycemia. Now, American Diabetes Association actually have given the different definitions of hypoglycemia. Now, what is severe hypoglycemia? What is mild hypoglycemia? You can see that the hypoglycemia, when requires assistance of somebody else to correct, is severe hypoglycemia. And again, hypoglycemia which do not require an assistance is a mild hypoglycemia. So there are a lot of fallacy as far as this definition is concerned. You can see that the young children, they always require the help of their parents to correct the hypoglycemia. So it is always severe hypoglycemia for them as far as this definition is concerned. Now then again, we have documented symptomatic hypoglycemia, means the patient has got a symptom, patient has checked his blood glucose, and it is documented. So it is documented symptomatic hypoglycemia. There may be asymptomatic hypoglycemia. Often you will find that the patient will come to your clinic. They have no symptoms, but the blood glucose level is 60s, 58, something like that. So it is documented that there is an hypoglycemia, either in the meter or in the lab, but the patient had no symptoms. So this is asymptomatic hypoglycemia. There is a probable symptomatic hypoglycemia, means that the patient has got a feeling of hypoglycemia, symptoms of hypoglycemia. The patient did not measure his hypoglycemia. He did not have a meter at that point of time to measure the hypoglycemia. And the patient consumed some carbohydrate and the hypoglycemia disappeared. So this is probable symptomatic hypoglycemia, as because the patient has not measured, so we cannot say that it is a documented hypoglycemia. So it is a probable symptomatic hypoglycemia. Sometimes there is a possibility that the patient has got a symptom of hypoglycemia, but when we checked, that blood glucose level is normal. This occurs someone have got a very long standing and very high level of blood glucose, say for example 400, 450 for a long period of time. Now you have started an insulin or some other agent, say mostly we start insulin at that level of blood glucose, and the glucose value very quickly came down from 450 to 200, and the patient has developed some symptoms of hypoglycemia. So we call it relative hypoglycemia because the fact there is a symptoms of hypoglycemia, but when we have measured the glucose, it is 200. So it is not satisfying the laboratory diagnostic value of hypoglycemia. So we call it relative hypoglycemia. There is a change in the blood glucose level rapidly over a period of time, and within a short period of time, and then the patient has developed the symptoms of hypoglycemia. Now there are a lot of symptoms and signs of hypoglycemia, and all of you are aware of these symptoms and signs, but let me tell you that all symptoms or signs will not be present to every individual, and some of the patient can have very atypical symptoms. One of my type 1 diabetes subject told me that he used to identify hypoglycemia when there is a double vision. He told me there is a young boy of 10. He said that whenever I see double, I understand that there is a fall in blood glucose level. So that is the way by which he used to identify his hypoglycemia. Diplopia is definitely one of the symptoms of hypoglycemia or signs of hypoglycemia. But the issue is, this is the method by which he used to identify the hypoglycemia. Now, all the symptoms, as I've told you, may not be present to every individual, and some of the patient may have the typical symptoms of weakness, tremulousness, nervousness, sweating, but you can have some atypical symptoms and signs as well by which the patient identify the presence of hypoglycemia. There may be possibility of neuroglycopenic symptoms, but this usually occurs when the hypoglycemia is quite severe and it has gone below, say, 40 milligram or 35 milligram per diem. So blurred vision, diplopia, lethargy, headache, inability to concentrate, loss of memory, confusion, bizarre behavior, motor incoordination, paralysis, seizure, coma. So these occurs when there is a neuroglycopenia and when the blood glucose level is very low. So basically, the first kind of symptoms usually are the adrenergic or autonomic symptoms, and this second group of symptoms or signs are basically of neurogenic symptoms, and this depends on how much blood glucose levels are. Now you can see that the mild when there is a hypoglycemia is in the mild range between, say, 50 to 70. There is usually a sweating, tremor, all are the adrenergic symptom which usually we find. Now once the blood glucose level goes below 50 or 54, so there is a cognitive dysfunction starts, and when it goes below 20 or 18 or 20, it means there is a severe neuroglycopenia when there is a seizure, convulsion, coma, and which may land up into death. So therefore, the hypoglycemic symptoms actually depends on the level of blood glucose in most of the situation. So the adrenergic symptoms which occur when the blood glucose level is mildly low in the range of 60 to 70 or 55 to 70, then actually patient can understand something wrong is happening. And this is the premonitory symptoms of hypoglycemia, which has got a great importance as far as identifying the impending risk of development of neuroglycopenia. So how the body responds to that of the hypoglycemia? As you know that when the blood glucose level falls, it is basically measured at the level of the brain. So hypothalamus is an efficient organ which actually measures the glucose level, and once the hypoglycemia measures that the blood glucose level is falling, it takes a lot of action. Number one, it stimulates the appetite and food-seeking behavior, and then it also releases the stored energy. So the hepatic glycogen is broken down into the glucose. It suppresses the insulin secretion and increases the glucagon secretion, so that there is liberation of the glycogen into the liver, and also the glycogen into the muscles, and liberation of the energy from the stored glycogen. So the first response of the body as far as the hormonal function is concerned is to stopping the insulin secretion. This is the first response. So if we look into the second response, the second response is to increase in the glucagon level. So when the glucagon level goes up, then you will find that the alternate energy stored, that is fat, glycogen, and sometimes the protein, they are progressively broken down. And the alternate energy substrate, the ketone body fatty acid, they gradually goes up. To a lesser extent, lactate and amino acid, because this is the protein product that actually occurs if the hypoglycemia persists for a long period of time, as we see in starvation. The conversion of some of the amino acid into glucose is basically by the process of gluconeogenesis. Also, as I've told you, that the glycerol, which is a product from the triglyceride, is also come for the production of gluconeogenesis. So the shift in the metabolic process from the glucose to energy source as free fatty acid and ketone body occurs if the hypoglycemia persists for a long period of time. So there is a metabolic shift from the glucose-dependent metabolic process to the fat-dependent metabolic process. Now, as I've told you, that the hypothalamus is basically the area where it is basically measured that the blood glucose level is low, which leads to the impulse into the release of the cortisol from the adrenal, and also it also stimulates the release of the adrenaline. So adrenaline actually gives rise to all adrenergic symptoms what we perceive when the blood glucose level falls. It also actually prevents the liberation of the insulin from the pancreas, and also increase the release of the glucagon, which is basically a most important counter-regulatory hormone, and that actually shifts the metabolic process from glucose-dependent process to the fat-dependent process. Now, this also actually increases the release of the growth hormone, which is also a counter-regulatory hormone as far as the insulin secretion is concerned. So the first action of the body is to stop the insulin secretion. Second action of the body is to produce the glucagon, and then the third action is to produce the adrenaline, cortisol, growth hormone, that is the other anti-insulin hormones or a counter-regulatory hormone. And because of the fact there is a production of adrenaline, there will be symptoms of adrenaline release or adrenergic symptom, which is basically the warning signs of the hypoglycemia. So coming to the metabolic aspects of the hypoglycemia, as I've told you, that if we look into the hypoglycemic aspects, there is a decrease in the blood glucose level. When there is a decrease in the blood glucose level, what the body will do? Body will try to produce more glucose. So how they can produce more glucose? There are two mechanisms by which the glucose can be produced. One is gluconeogenesis, another is glycogenolysis. So both this process, gluconeogenesis and glycogenolysis, is basically carried out by the counter-regulatory hormone, that is glucagon, cortisol, growth hormone, adrenaline. So this counter-regulatory hormone is responsible for these two important processes, gluconeogenesis and glycogenolysis. Therefore, whenever there is a hypoglycemia, these four hormones secretion goes up. And because of these four hormones, especially the glucagon and the adrenaline and the cortisol, they will try to break the lipids. So by breaking the lipid, they will produce glycerol and free fatty acid. And as I've told you, glycerol will be utilized in the gluconeogenetic pathway, and the free fatty acid will be utilized by the liver to produce the VLDL. Now, when there is a proteolysis, there is a production of the amino acid, which is again will be utilized by the gluconeogenesis pathway. Now, muscle glycogen cannot be broken down into glucose, so they are broken down into the lactate, and this lactate is taken up by the liver for the production of gluconeogenetic pathway. So ultimately, the intention of the body is to produce more glucose. How they will produce more glucose? By producing more anti-insulin hormones or the counter-regulatory hormone. These counter-regulatory hormone will mobilize the lipids and the proteins from the peripheral tissues, and they also break down the glucose in the muscles and in the liver. In the muscles, they cannot produce glucose, but they produce lactate, which indirectly produce the glucose. In the liver, the glycogen breakdown directly produce the glucose, so glycogenolysis. So this is the method by which the body tries to correct the hypoglycemic insult. So in type 1 diabetic subjects, mild symptomatic episodes are common and most likely to develop before meals and during or after exercise. One episode a week among the patient, those who are on conventional therapy, and 2 episodes a week, those on intensified treatment. Severe hypoglycemia in adult patient on conventional therapy, 1 in 3 will experience hypoglycemia coma at some point in his or her treatment. Of these, 1 in 3 would have experienced coma in the previous year. Of these, 1 in 3 are incapacitated, frequent and severe episodes of hypoglycemia. So hypoglycemia is a very, very important issue in the management of both type 1 and type 2 diabetic subjects, and we must be very careful to try to avoid hypoglycemia. We'll talk a little bit about the consequences of hypoglycemia as well. So in type 2 diabetes, the possibility of development of hypoglycemia is much less frequent compared to type 1 diabetes. Among patients, those who receives non-hypoglycemic medications, the possibility of hypoglycemia is very rare. It becomes more common as patients reach the insulin deficient state of the spectrum, and when they start taking the insulin therapy, the possibility of hypoglycemia goes up. Overall incidence of hypos in insulin-treated type 2 diabetic patient is 1/3 of the type 1 diabetes. So even though a type 2 diabetes treated with insulin, the possibility of hypoglycemia is very low, because the fact in most of the situation in type 2 diabetes, we treat only with basal insulin. And the possibility of development of hypoglycemia with basal insulin is very low. So it is quite safe. Now coming to the pharmacology of the hypoglycemia, the insulin reaction, there may be factitious insulin injection, there may be sulfonylurea, ethanol, beta blocker, or some other medication like quinine, chloroquine. So they are actually can precipitate the hypoglycemia. So we have to remember whether the patient is receiving any of these kind of drugs or not. Insulin-induced hypoglycemia is the commonest, and when you are giving regular insulin, it occurs within the next 2 to 3 hours period of time. If you are giving an NPH insulin, then usually it occurs late, 8 to 10 hours. hypoglycemia is much less with, if we look into the data as far as we have with the use of glargine, detamine, or degludec. Now, the hypoglycemia can occur because of error in insulin injection. Sometimes I have found that the patient has actually made mistakes, that the dose that should be taken in the morning have taken at night, or sometimes the dose which is supposed to be taken in the night is taken in the morning. So if they mix up the dose quite naturally, both the dose may not be the same, and if they take excessive dose, the possibility of hypoglycemia will be very high. Now, if you are giving two different insulin, then there is a confusion, maybe more. So that is why it is better to avoid prescribing a patient 2 or 3 different varieties of insulin. So avoid different varieties of insulin, especially among the elderly subjects. So give only one variety of insulin, so that the patient have no chance of actually mixing between the short-acting or long-acting insulin. Now, timing of the insulin in relation to food is important, as you know that the regular insulin should be taken 20 minutes before the meal or half an hour before the meal. The short-acting insulin or the insulin analog, short-acting analog insulin should be taken just before the meal, or you can take just after the meal as well. For the long-acting insulins, it has got no relationship with the meal. So the issue is, unless and until people remember that what is the advice and the correct time to take the insulin, there is a possibility of hypoglycemia. If the patient has taken an excessive dose, especially if they mix up with the IU40, IU100 syringe, it is one of the very common mistake, and that may have a devastating result. So sometimes the pharmacy has a short supply of U40 syringes and they give U100 syringe. And if they have a short supply of U100 syringe, they give U40 syringe. If you mix up between the U100 and U40 syringe, there is a possibility of very high insulin dose, 2.5 times, or very low insulin dose. Both actually can have devastating consequences. Now, sometimes if you do a exercise after taking the injection, there may be rapid absorption, and that may actually can precipitate the hypoglycemia. So that is an important issue. Exercise itself can precipitate hypoglycemia, especially if it is an unaccustomed exercise. If you are doing the same exercise every day and your insulin injection is basically adjusted with that amount of exercise, then there is no problem. But sometimes if you are doing an unaccustomed exercise, and more so if just after taking the injection, the possibility of hypoglycemia is much higher. It is better to avoid the hypertrophic injection sites, because if you, especially in case of type 1 diabetic subjects, if you examine the insulin injection sites, you will find that there is a lipodystrophy or lipohypertrophy. And if there is a lipohypertrophy, the child is always interested to inject in that particular site because it is much less pain, cause much less pain. But we have to insist and teach the child not to take the insulin in that hypertrophic injection site, because the absorption of the insulin is unpredictable, and therefore there is an erratic blood glucose level, including there may be a possibility of hypoglycemia. So excessive insulin level, which can cause hypoglycemia, it may be an error on part of the patient or by doctor or by pharmacist. There may be a poor matching to the patient needs and lifestyle. There may be deliberate overdose, fictitious hypoglycemia. Sometimes because of increased bioavailability of the insulin, as we have already discussed, in exercise or injection into the abdomen, or if you are giving in a lipohypertrophic area, insulin antibodies, and the renal failure is associated with precipitation of hypoglycemia because of the fact that kidney is basically a site in which the insulin is basically cleared or metabolized. So once there is a renal failure, the insulin metabolism is low, or less amount of insulin is cleared, and therefore the possibility of hypoglycemia goes up. So there are some precipitating factors for the hypoglycemia. Very importantly, we have to remember two important endocrinopathies, Addison's disease and hypopituitarism. Hypothyroidism is not very important, but Addison's disease and hypopituitarism is very, very important factor. And as I can tell you that some of the type 1 diabetic subjects can have Addison's disease as well, because both are autoimmune disease. So that we have to remember in mind. Weight loss, physical training, postpartum period, and menstrual cycle variation. When someone is recovering from infection, so the patient when had pneumonia used to receive say 60 units of insulin. Now when he starts recovering from infection, the requirement will go down, and if you are not down titrating the insulin dose, there's a possibility of hypoglycemia. Now the patient may have missed a meal and started some slimming diet, or suffering from anorexia nervosa, vomiting, or breastfeeding, or if you fail to cover the exercise, for which we always ask our patient to check your blood glucose before you are starting the exercise. Or sometimes the patient wants to start a new exercise regime. In that case, we have to adjust the dose of insulin. We have to ask the patient to frequently check the blood glucose level before starting the exercise or after exercise, to get an idea that whether the insulin dose is adjusted, or we need to down titrate or up titrate the dose of insulin injection. So precipitating factor for hypoglycemia may be exercise, alcohol, and drugs. Say for example, salicylates, beta blocker. So and sometimes the pentamidine, they actually can precipitate the hypoglycemia. Sulfur-induced hypoglycemia is caused among 5% of the patient, which may be increased if the patient has got an advanced age, or if there is a starvation or hepatic renal disease or adenocortical insufficiency. So these are the causes of hypoglycemia among patients, those who are receiving sulfonylurea. Now this is a 45-year-old male, has a diabetes type 2 for the last 5 years, is currently on combination of glimepiride 2 milligram and metformin 1000 milligram twice a day. His fasting and PP blood glucose values are 85 and 128 respectively, and HbA1c is 6.2. During a dinner party, he consumed 250 ml of whiskey. He got up late in the morning with severe headache, body ache, extreme weakness, palpitation, perspiration. Glucose meter showed that the fasting glucose at 10:30 a.m. was 45 milligram per dl. So as you can see that this patient actually has developed an hypoglycemia, and what we should advise the patient, because you know that the ethanol itself can induce hypoglycemia. The possibility that it is basically prevent the gluconeogenetic pathway, this is one of the explanation, and also because of the fact that when someone take alcohol, they take less amount of carbohydrate. So they take something of protein or the fat and don't take adequate amount of carbohydrate. But as because the patient has taken the anti-diabetic drugs or the insulin, and as because has not taken or eaten adequate carbohydrate, and as because the ethanol actually can block the gluconeogenetic pathway, so there is an increased possibility of hypoglycemia when somebody takes ethanol. The mortality with ethanol-induced hypoglycemia is quite high, 10%, and it can produce a blood glucose level very low and often precipitated by the fact of the low hepatic glycogen store. Say for a patient is a chronic alcoholic, and because the liver is damaged by the chronic alcohol consumption, there may be cirrhosis. So if there is a cirrhosis, hepatic glycogen store is very low. So quite naturally, the possibility of development of severe hypoglycemia is very high. So to treat the patient with intravenous infusion of glucose, and we may add vitamin B1, as because the patient was basically alcoholic. Now, beta blocking agent very occasionally can cause symptomatic hypoglycemia. More importantly, it actually masks the symptoms of hypoglycemia. That is why we try to avoid non-selective beta blockers, especially the propranolol. The precipitating factor may be chronic malnutrition, ethanol, exercise. Mechanism is not very clear, but this also possibly inhibits the hepatic neoglucogenetic pathway. The most important fact is that the beta blocker inhibit the autonomic symptoms of hypoglycemia. That is, the warning signs is actually inhibited by the beta blocker. So there may be some unusual symptoms of hypoglycemia like emotional lability, depression, vomiting. So as I've already told you that the hypoglycemia can have sometimes bizarre manifestations. There are some special issues related to hypoglycemia. One is hypoglycemia unawareness, another is nocturnal hypoglycemia and reactive hypoglycemia. I'll go through a little bit about this. Hypoglycemia unawareness means, as you know, that the warning signs of hypoglycemia depends on the adrenergic mechanism. Once there is a hypoglycemia, there is a production of adrenaline, and the adrenaline actually gives rise to the symptoms of hypoglycemia, that is adrenergic symptoms. Now, in some of the patients, actually this adrenergic symptoms is absent. Then we call it hypoglycemia unawareness. So the patient remains unaware when there is an episode of hypoglycemia. So this is very dangerous because the fact that the patient will not understand that they're facing an impending issue of neuroglycopenia or sudden neurologic symptoms without going through the adrenergic symptoms. So causes of the hypoglycemia unawareness is basically because of the long-standing diabetes. If the patient has got an autonomic neuropathy, and also if the end organ responsiveness is low, and if the patient has got a lack of sympathetic response, and sometimes and we call it the hypoglycemia associated autonomic failure. So when there is an hypoglycemia associated autonomic failure, it means that the patient has got a autonomic neuropathy associated with autonomic failure to understand hypoglycemia. We call it hypoglycemia unawareness. And as I've told you that this is often dangerous because the patient can land up into a neuroglycopenic symptoms directly into unconsciousness or seizure or coma. What we need to do is we have to educate the patient, and we have to train the patient to recognize the neuroglycopenic symptoms and get himself or herself treated immediately, because he will not face the adrenergic symptoms. We have to look into the management strategy of the patient, and if the patient is in tight glycemic control, we have to relax the control, and we have to avoid hypoglycemic episodes at least for 2 weeks period of time. So if we avoid hypoglycemia for 2 to 4 weeks period of time, there will be gradual return of the hypoglycemia awareness. So patient can recognize, the patient can again have adrenergic symptoms, and this is quite safe to have the adrenergic symptom. Otherwise, if the patient do not have adrenergic symptom, they will directly land up into the coma without going through the monitoring pre-monitoring symptoms. So coming to the nocturnal hypoglycemia, that is also an important concern in front of us, because nocturnal hypoglycemia is associated with mortality. If someone develops hypoglycemia in the middle of the night, if it is severe, and if there is a precipitation of an arrhythmia, especially if the patient has got a background cardiovascular disease, the morbidity and mortality will be very high. So the patient may have early morning symptoms of headache, or sometimes there may be nightmare. So the best way to identify them to check the 3 AM blood glucose level. If you've got any doubt, ask the patient to check 3 AM blood glucose level. You can add a bedtime snack if the patient is taking early dinner. We have to reduce the night dose of long-acting insulin, and we have to relax the control of fasting plasma glucose. And it is always better to shift the patient to basal analog insulin from NPH if the patient is receiving. NPH mostly associated with this important issue of nocturnal hypoglycemia, and if we shift the patient from NPH to analog basal insulin, then the possibility of nocturnal hypoglycemia will go down. So this is the way we treat the nocturnal hypoglycemia. Another issue is the reactive hypoglycemia, which is found among patients who have early diabetes or pre-diabetes, as because the insulin secretion is slows during the early diabetic and pre-diabetic state. So the symptoms of hypoglycemia develops after 4 to 5 hours of the meal, and it is usually found in the obese individual. And the symptom disappear when the over diabetes develops. The treatment is by reduction in the body weight, and also you can ask the patient to take frequent small meals. And this can be diagnosed by an extended oral glucose tolerance test. So how to do this? If the patient has got symptoms of late hypoglycemia, so you do the test for 5 to 6 hours. And over 5 to 6 hours, if we check the blood glucose level, you will find that after 5 or 6 hours, you can find that the blood glucose level goes very down. So this is known as reactive hypoglycemia. It sometimes occurs among patients after bariatric surgery or some other gastrointestinal surgery as well. This symptomatic hypoglycemia occurs 3 or 4 hours after the meal, and we have to treat the patient by asking to take small meals at frequent intervals. So morbidity of hypoglycemia are a lot. Now there may be some neurological issues like coma convulsion, transient motor or sensory deficit, ataxia. There may be a possibility of permanent brain damage, intellectual damage. There may be psychological issues of cognitive dysfunction, automatism, psychosis. Cardiovascular issue is very important because in some of the trial we have found that the tight glycemic control was associated with increased mortality, and some explanation for the increased mortality is because of increase in the cardiovascular event precipitated by the hypoglycemia, because of the fact that in the trial the people tried to reduce the blood glucose to a very tight level. So the possibility of vitreous hemorrhage may be there. There may be a fracture during convulsion, and also the accident, which is a very important issue when the patient has got a hypoglycemia. Now this is Mr. F, a 62-year-old. He has had diabetes for the past 28 years. He's taking glibenclamide 5 milligram twice daily, metformin 5 milligram thrice daily, and pioglitazone 30 milligram once daily. And one day he was brought to the emergency department by his son in an unconscious state. And his son says that his father is very systematic in taking the medication. Yesterday night also has taken all medicines and has taken his dinner, though he could not take his usual diet due to some stomach disorder. And when the capillary blood glucose was done, it showed 32 milligram per diem. So what condition it is? So this is basically the patient is suffering from hypoglycemia, and how you start treat this patient and how we can prevent the hypoglycemia in future. So these are the issues in front of us. Now how we treat? Now it depends on whether the patient is conscious or unconscious. If the patient is conscious, can take orally, then the oral carbohydrate is the best way to treat the hypoglycemia. Usually we require to give roughly around 15 to 30 grams of glucose. The best is to give glucose drink because it is easily dissolved in the water, and I always prefer to give the glucose. If the glucose is not available, then you can give some other agents, say for example sugar. You can give candy, orange juice. So these are the things you can give, but the glucose is best because you can measure. We can give 15 gram to 30 gram to correct one episode. You give 15 gram, check the sugar after 10 minutes or 15 minutes time. If it is not corrected, give another 15 gram. But if the patient is unconscious, it is better to give an IV glucose. And usually the IV glucose we give 100 ml 25% dextrose means roughly around 25 gram. That is more than sufficient to correct most of the hypoglycemic episode. 100 ml 25% solution. So check the glucose value again after 10 minutes to see whether the hypoglycemia has been corrected or not. In case of type 1 diabetic subject, it is always advisable that we should teach the patient to self-inject the glucagon. It is a very good method by which the hypoglycemia can be corrected. Glucagon is available 1 milligram prefilled insulin, prefilled syringes, and this prefilled syringe the patient should keep as an emergency kit, and every child knows how to inject the insulin subcutaneously, and glucagon also can be given subcutaneously. This therefore very easy for them to get a glucagon shot when there is an episode of hypoglycemia. So as I've told you that for the management of acute hypoglycemia, you have to check whether the patient is conscious or unconscious. If the patient is conscious, give the oral glucose. Check blood glucose after 15 minutes period of time and confirm the recovery. If the patient has recovered, then it's okay. If it's not recovered, you should repeat the dose. If the patient is unconscious, on the other hand, you have to give IV glucose or glucagon 1 milligram subcutaneous injection. If there is a recovery, well. If there is no recovery, you have to repeat IV glucose again. Now we have to identify the cause of hypoglycemia. We have to educate the patient so that we can avoid the development of hypoglycemia in future. Sometimes the glucagon may lose its effect with repeated use. Glucose gel is not available in our country as far as my knowledge goes. Glucagon we don't give among patients those who are using sulfonylurea. So glucagon is a drug for type 1 diabetic subjects. Sometimes sulfonylurea-induced hypoglycemia may be very prolonged, and you have to give a glucose drip for a long period of time. But when you are giving a long-acting preparations of sulfonylurea. So prevention strategy is to check regularity in the diet, exercise,